Hello, everyone, and welcome to another community conversation on the health crisis and WHO.
Share all resources of personnel.
That's a great question, and I would direct them to the
thinking outside the box, trying to come up with ways of
As you already mentioned, the city is
Let's try to keep these numbers from doubling.
At over 33%.
First, I want to say thank you for inviting me to the show.
Well, good afternoon, everyone. It's Friday at noon, so it's time for another community conversation right here on Facebook Live. I'm Mayor Eric Pappenfuss. I hope everyone had a happy and safe holiday. We're back live this week, and we'll continue so as we move forward in the new year. We're very fortunate today to have Dr. John Goldman with us. He is an infectious disease specialist and Vice President of Medical Affairs at UPMC Pinnacle. And our topic today is going to be the vaccine and basically how we how we all work together to get the other side of this pandemic. It's an important conversation, perhaps one of the most important conversations we've had on the show, and I've been looking forward to it for some time. I just wanted to begin with two short announcements. The first has to do with Christmas tree disposal, just so that everyone is aware. Your Christmas trees, once you've removed the ornaments and lights and whatnot, can be placed on the curb for street sweeping nights. We will pick them up during street sweeping times, so you should put them out the night before street sweeping in your neighborhood anytime during the month of January. After January, you'll have to put them out with the trash because we're only doing the specialized Christmas tree pickups in the month of January. But either way, street sweeping nights through January 31st in Harrisburg, please, for your trees. And then we will have them mulched and composted. Another general announcement, there's only one city council meeting for the month of January that's been planned, and they will be back in session on January 19th. So that's Tuesday the 19th at 6 p.m. And we are going to continue to hold those sessions virtually. So you'll have to get the link and participate then on the 19th. And as always, we will begin with the BioBot data. And Dr. Goldman, you might find this data interesting. We've been releasing this sort of every week on the show. This is the wastewater epidemiology, which has been done by a company called BioBot out of Cambridge, Massachusetts. They analyzed the wastewater samples for Capital Region water, which includes not just Harrisburg, but the surrounding municipalities, and sort of track those on a graph along with the actual reported cases. And usually, the wastewater prediction from their analysis is significantly higher than what's actually being reported based on the number of people that are being tested. And you see that again this week. This is a weekly test. You see that we're continuing to be amidst a fairly significant spike. We are way above where we were even in November. And that's part of why we have to continue to take this virus so seriously. The next graph shows where we are in relation to other cities and counties and municipalities throughout the country that are being tested. And I have not been able to come up with a significant answer to why it is that the Harrisburg region seems to have a higher concentration than 92% of all the other areas that are sampled throughout the country by a BioBot. That's something that maybe we could think about and talk about a little bit today. That was a question that came up from one of our viewers even last week or 2 weeks ago before the break. But there was just a paper which BioBot released in a medical journal which prominently features Harrisburg and others, and continues to sort of make the case for a national wastewater monitoring system, as that it really does get to sort of geographic and other trends. The top graph again shows that Harrisburg's concentration is fairly high compared to elsewhere in the country, and the estimates are based on the BioBot data that we're experiencing right now, about 300 new cases a day in Harrisburg and the Harrisburg metropolitan area. And people may not be getting tested, may not even know they're carrying it because they can be asymptomatic, but that is the prevalence of the virus in the community as estimated by BioBot. But Dr. Goldman, you're here today to talk about the vaccine, and I wanted to premise our conversation with a meeting that I had yesterday. It was a labor management meeting, and I met with some of the first responders who work for Harrisburg, and I was surprised to see the number of questions that they had about the vaccine, and frankly the resistance that many of our first responders even have to voluntarily being vaccinated. And I feel that if we haven't even made the case to convince our first responders of the importance of the vaccine, then we definitely need to do more to educate the public. And this is a real challenge because if enough people don't voluntarily get vaccinated, then ultimately the vaccine won't work in the sense that we have to vaccinate a significant percentage of the population. So, but most of the questions that they had were factual and were just basic about whether it was safe or how it works. So let's start with the very basic question of how do vaccines work generally, and how does this vaccine in particular work?
Vaccines work in one of two ways. Either by giving you an inactivated virus or a very similar virus that can't infect you. So for example, a measles vaccine is a live vaccine. You're being given a live virus that's attenuated. It means that it's been weakened, and so it does not cause disease in people. What happens is that your body recognizes the virus. It generates antibodies. It generates an immune response. And so next time your body sees the virus, the response is much, much, much quicker. So when your immune system has been primed, meaning that the immune system has already seen the virus, the bacteria, its response is a lot quicker. So there are a number of viruses: measles, mumps, German measles, chickenpox, that once your body recognizes the virus, you're immune to it. You never get it again. So instead of getting natural infection, having to be infected with the measles virus, you're infected with a weaker virus that doesn't cause disease, so that when if you actually encounter the real measles virus, then your body recognizes it and fights it off before it can make you sick. The other thing, for example, the flu vaccine does this, is you take a small piece of the virus. Your body recognizes that small piece as something foreign, something that's not supposed to be there, generates antibodies to it. And so even though you only have antibodies to that small piece, you're immune to the virus. So the two vaccines that are out right now, the Moderna vaccine and the Pfizer vaccine, are both actually novel viruses. They're what they call messenger RNA vaccines. In English, it's not a piece of the virus. It's not even a genetic code of the virus. It's not even one of the genes from the virus. It's the protein the virus makes. It's the RNA the virus makes so that the spike protein is made. So what happens is you're injected with this messenger RNA. It goes into your cells. Your ribosomes, the part of your cells that make proteins, manufactures spike proteins. There's no DNA involved. The messenger RNA that is going into your cells stays in the cytoplasm of the cells, the part of the cell, the water between the nucleus where all the chromosomes are and the cell wall. Never gets anywhere near your genetic codes, your chromosomes. And for a short period of time, makes spike proteins. And then your body chews up the messenger RNA. Your body stops making the spike proteins. But your immune system recognizes those proteins as something that is not supposed to be there, develops antibodies to it. And within about 1 to 2 weeks, people who were given the vaccine started to get much lower COVID, a lot less frequency than people that were given placebo and not given the vaccine, given an injection of saline. But you get a second shot with the Pfizer vaccine at 3 weeks, with the Moderna vaccine at 4 weeks. And with that second shot, you should be getting long-lasting immunity. If you are infected with the COVID virus, your body immediately recognizes its spike proteins, already is primed to make antibodies against them, and fights it off. So one of the questions people frequently ask is how well does this work? Well, it works 95% of the time. If 100 people who got placebo got COVID, only 5 got COVID who got the vaccine. Now, what some people hear, and this is actually much better than our typical vaccines. The flu and measles, the measles shots are typically very good, 80-90%. The flu shot works about half the time. But the COVID is actually very good. It works much better than our typical vaccines. And with most vaccines, if you get the disease, despite getting the vaccine, you're much less likely to get really sick. So for example, with the flu, which I said works about half the time, people who get the flu shot and still get the flu are much less likely to end up in the hospital, much less likely to get really sick, much less likely to die. So the vaccines work by priming your immune system. They put something into you that can't make you sick, either a weakened vaccine or a protein from the vaccine or a gene from the vaccine that makes a protein, that makes part of the vaccine. And your body recognizes it as something foreign, makes antibodies against it, has an immune response. And so the next time you see, if you're infected with if you come in contact with the natural virus, your body's already able to fight it off, and most people will not ever get sick.
That explanation, I think it was clear. I think there is a general misperception that's out there that perhaps you can get COVID from the vaccine. That and I think you've explained that you can't. But just to give a little bit more of an explanation about how this isn't an actual injection of COVID into your arm.
So a couple things. Saying that you could get COVID from this is kind of like saying you could build a car from a tire. You're only getting a small part of the protein, what are called the spike proteins. These are the virus is kind of a circle, and there are these little proteins that look like spikes that attach to your cells and allow the virus to enter your cells. And so not only is this not a live virus, this isn't even a whole virus, for example, a killed virus. It's just one gene or one copy of the RNA that's produced by a gene that has your body make just those spike proteins so that your body gets an immune response, makes antibodies, and is able to fight off the virus with the antibodies to those spike proteins. It's not a whole virus. It's not a killed virus. It's not even it's only your body only makes a small part of the virus.
Thank you. That's very clear and I think really important. So you mentioned the two companies, Pfizer and Moderna, that are making the vaccines that we know about now. Are there any important differences between those two vaccines, and will the public be able to choose which vaccine they may get?
There are no differences in the vaccine safety. There's no difference in how well they work. They're made by two different companies. They both work in the same way. They both have the messenger RNA, which produces the spike protein, and both of them, within about 2 weeks, give you significant immunity. People at about 2 weeks after their first injection are much less likely to get COVID, and both work really well, 95% of the time. And for a vaccine, especially a first vaccine, this is really good. There's some subtle differences. Both require 2 shots, but the Pfizer vaccine, you get the shot on day 21 after 3 weeks. The Moderna vaccine, you get the shot on day 28 after 4 weeks. The Pfizer vaccine has to be kept at ultra cold temperatures, negative 93 Fahrenheit. That's like being on Antarctica. It has to be kept on dry ice. It has to be kept on special freezers. It is much harder to handle. The Moderna vaccine also has to be kept refrigerated, but not in an ultra cold way, and it's easier to handle. And right now, people are getting the vaccine that's available. You have to remember that in the United States, there are about 330 million people, and so far we have 20 million doses of the vaccine. So we're giving it to healthcare workers first. We're giving it to nursing home residents first. We're going to give it to first responders next. We're going to give it to people who are at high risk of dying if they get COVID. But most people are going to end up getting the vaccine that's available. You won't be able to go to your pharmacy and say, oh, I'd like the Moderna vaccine or I'd like the Pfizer vaccine. It's almost certainly going to be what's available at the time. There are not large differences between the vaccine. Both of the vaccine have allergic reactions, something called anaphylaxis, which is a severe allergic reaction. And about 1 out of 100,000 doses. That's higher than most vaccines. Most vaccines are about 1 in a million. On the other hand, people who get COVID, so the youngest people, the healthiest people, about 1 out of 1,000 die. So literally, your risk of dying if you get COVID is roughly 100 times more than your risk of having a non-fatal reaction to the vaccine. That's only for younger people. So if you're my age, in your 50s, you have a 1 or 2% chance of dying. Now that doesn't sound really bad. You'll see, people on Facebook going, 99% of the people survive this disease, but that's 1 out of 100. So you have a 1 out of, if I got COVID, I'd have a 1 out of 100 chance of dying from COVID, compared to a 1 out of 100,000 chance of a non-fatal reaction for the vaccine. For me, getting the vaccine, and incidentally, I had my first dose about 3 weeks ago. All I got was a little bit of a sore arm and no other side effects. But my chances of dying are 1,000 times more. My chance of dying from COVID are 1,000 times more from a non-fatal reaction to the vaccine. Now, older people, if you're 70, you have a roughly 1 in 10 chance of dying from COVID. So you have a 10,000, your risk of dying from COVID is 10,000 times your risk of the vaccine. People often say, well, the vaccine just came out, so they're not sure of the side effects. That's absolutely true. This has been around much shorter, and often rare side effects from vaccine come out when we start to give it to a million people, 10 million people. But the key word there is rare. So it is not, even for a young person, rare to die from COVID, 1 out of 1,000 cases. It's common if you're above the age of 70, somewhere we're about 1 out of 10 cases. And the risk, and 4,000 people yesterday in the United States died from COVID. That's the equivalent of more than a 9/11. We've been having the equivalent of 1 9/11 every day in the United States. So often we're taking vaccines for kind of rare causes. We vaccinate people all the time for rabies. We've had 18 cases of rabies in the last 20 years in the United States. We see 4 or 5 cases of measles every year in the United States. And we vaccinate everyone precisely because then if someone gets measles, it doesn't spread. It prevents, and rabies, for example, is fatal. On the other hand, we're seeing 200,000 of cases of COVID every day. We're seeing 2,000 to 3,000 deaths every day. And if you are, especially young people, if you are not vaccinated, you will get COVID. So everyone who is not vaccinated will eventually get the disease. Because right now it's going very quickly through the population. The way we will end this is with vaccination.
Well, thank you. Thank you for sharing those percentages. They really do put it in perspective. And we'll talk a little bit more about that in a minute. But let me ask you the basic question of, how quickly does the vaccine work? You mentioned the 2 doses. You've gotten your first dose. Are you protected now, or are you not protected until you get the second dose? And as a corollary to that, how long will it last? Is this the type of vaccine that we're going to need to get every year, or is that undetermined at this point?
So, first of all, you are officially immune 1 week after your second dose. So you receive 100% immunity 1 week after your second dose. You're probably significantly protected 1 to 2 weeks after your first dose. So right now, instead of having if I was exposed to COVID, instead of having the vaccine work 95% of the time, my guess is it would work 60, 70, 80% of the time. But the vaccine is considered to be fully effective a week after your second dose. As to how long the vaccine immunity lasts, no one knows that. With natural infection, we assume that it lasts at least 3 months. We don't really know how long it lasts. Coronavirus, the type of virus COVID is, often doesn't produce antibodies for you often can get a cold twice. It's not clear yet if your immunity is from natural infection is lifelong, or if your immunity from the vaccine is lifelong. Some viruses, measles, chickenpox, hepatitis, it's generally one and done. So you have very long-lasting immunity, 10 to 20 years, often lifelong. With the flu shot, the virus changes a little bit each year, so you have to get a shot each year. And we don't really know whether COVID will be one of these things that you'll get a single shot and then it's all done, or you'll have to have more frequent shots, maybe even more as frequently as once a year. We do not know that yet. I will point out, though, that we have experience with viruses like this that first appear. We're not immune to them. And there was a new flu that appeared in the United States in 1968. It's called an H3N2 strain. And in that year, it killed 100,000 Americans. The first time flu went through the typical flu season kills about 10, 20,000. That strain is still around with us today, but because we have partial immunity, meaning we've been exposed to similar viruses before, and because vaccination, when you have it come through, that's just the typical flu season. It's not worse it's a little worse, but not a lot than the regular flu. Even if the vaccine doesn't produce full immunity, even if it doesn't produce lifelong immunity, we're not going to be living like this for the rest of our lives. With a vaccine, with partial immunity, this will in fact become just the flu. It is possible we'll still need flu shots. But once people are exposed to the virus, it doesn't spread as quickly through the population. And once people have partial immunity, even if they get sick, they don't get nearly as sick. So this pandemic will end. It will end even if COVID is still around, even if we still occasionally get sick from it. With vaccination, with partial immunity, we will it will be something like a regular flu season. We certainly won't be quarantining, and we certainly won't be wearing masks.
Great, thank you. Talking a little bit about the 2-shot process, since you have to get two shots, is it possible, since supply in general is not up to demand, that you might run out of the second shot before you were to get it? And also, as a corollary to that question, what happens if you get the first shot and then forget to get the second shot?
The second shot is to give you longer immunity. And the second shots are supposed to produce more of an immune response. As a result, people get sicker, have more flu-like symptoms, have more fevers with the second shot. And so if you don't get the second shot, your immunity is likely to last less long. It won't be as strong or as long. If you get the second shot late, you may actually get a stronger immune response, but you're more likely to get side effects. Right now, there is an army of people making sure that if we get the first shot, we get the second shot. So for example, at our hospital, we were given a first box of vaccine, and then 3 weeks later, we're given a second box to revaccinate all the people who got vaccines from the first box. There is talk, because the vaccine is short, of only giving one shot, particularly the Moderna vaccine. The problem is that we don't know what really happens. It wasn't studied that way. And so we don't have good data on whether that will produce the same effect, if that will produce as strong a response, if that will produce as long a response. And so in general, we are trying to give people both shots.
I would think logistically it would be, maybe it's straightforward to do now when the number of people being vaccinated is somewhat limited, but once we have the wider rollout to the larger population, it might be difficult to track how to get recontact people and get that second shot.
I'm sure that it will be, but you have to remember that we have done this a lot. So for example, when you get childhood vaccinations, most childhood vaccinations take more than one shot. If you get a hepatitis B shot, you actually need 3. When you first get the flu shot as a child, you need 2. Now it's going to be done on a larger scale, meaning it'll be done with many more people. You're not just vaccinating kids, you're vaccinating everyone. I expect it will be difficult, but I also suspect that people will be highly motivated to get their second shots.
Sure. Well, one question that comes up a lot is cost. And the real question, is the vaccine free? Would it be free if you don't have insurance? And put cost in the context here.
So right now, this is all paid for by the government. So when I got my shot, no bill appeared on my insurance company wasn't billed. I wasn't billed. And so right now, everyone who is getting the shot will get it for free. I assume that's going to be the case with the first wave of shots. It probably won't be free forever. Nothing is free forever. So it's actually a good reason to get it now because it's free rather than waiting.
Okay, so let's talk about, I think you mentioned already that right now it's available to some first responders, EMS, medical professionals, nursing homes. Can you talk about the rollout? When will members of the general public expect to be able to get the vaccine? And I know some of that may be unknown, but what's the plan?
Plan is nursing home residents, healthcare workers, followed by first responders, and then starting to vaccinate high-risk people, particularly those above the age of 75, followed by the higher-risk people, followed by the general public. As I understand, we are supposed to get 20 million doses of the vaccine we were supposed to get 20 million doses of the vaccine by the end of December, 30 million by the end of January, 50 million by the end of February. So we'd have about 100 million doses. We'd be able to vaccinate about 50 million people. I personally think that most of the general public will start to get it in March, April, May. And some of that will simply depend on vaccine supply, how quickly the companies are able to make this and how quickly we're able to get the vaccine out. Also depend on how quickly other vaccines become available. The AstraZeneca Oxford vaccine, the one that's been approved in England, is a single shot. It's much easier. It doesn't have to be kept as cold. I suspect more people will be vaccinated when that vaccine becomes available. So it's really going to depend upon how quickly the vaccine can be manufactured, how quickly we can get it, and then the logistics, how how you get it in trucks, and how you get it to people.
Great. And are there some individuals that we're recommending not get the vaccine? You mentioned the possibility for allergic reactions. I suspect if you have a personal history of severe allergies, maybe. But I also had a question about pregnant women. Is it recommended for them to get the vaccine?
So pregnant women, it wasn't studied in pregnant women. And so right now, the American College of Obstetrics and Gynecology recommends that women get it with the knowledge that it wasn't studied. However, the vaccines that are most dangerous to give to women are vaccines that contain a live virus. So usually you don't give one of the vaccines that has a live virus to a woman while she's pregnant. Vaccines that only contain a part of the virus are much safer, but we haven't studied it. On one hand, simply because of their age, pregnant women are at much less risk of COVID. They're young, their death rate is much lower. On the other hand, compared to non-pregnant women the same age, they're at slightly higher risk of getting a complication of COVID. And there is some data that because COVID can often cause increases in clotting, that it's a greater danger to the baby. So we typically discuss the risks and benefits of the vaccine with a pregnant woman. It's supposed to be what's called shared decision-making. You don't just say, yes, you should take this. You have a discussion about the risks and benefits. But my general recommendation is that people, the pregnant women, have to take the vaccine. The same question comes up about breastfeeding women, and same sort of discussion. It wasn't studied in breastfeeding women. We don't have good data, but in general, I recommend it. We have a discussion with the woman who's breastfeeding, and in general, my recommendation is that they take it. Now, as we talked about earlier, the allergic reactions occur in about 1 out of 100,000 people. So if you have had a previous allergic reaction to the vaccine or some component of the vaccine, you're not supposed to get it. Most people haven't had a previous reaction, and most people don't know the components of the vaccine. It is thought that you need to be more careful if you are someone who has had a severe allergic reaction called anaphylaxis, and you would know this isn't getting a little bit of a rash, this isn't getting a fever, this isn't getting an upset stomach, this is getting low blood pressure, swollen lips, trouble breathing. You would have been treated for this. And those people, you have to have another conversation about the risks and benefits and whether or not the risk of the vaccine is worth it. Again, we have given UPMC and UPMC Pinnacle, again, like 20,000 doses of the vaccine. We've had one allergic reaction. So it is still rare. One of the things that we do is we observe people for 15 minutes. So after you get the vaccine, you're supposed to stay where you got the vaccine in case you have a reaction for 15 minutes. For people who've had a history of anaphylaxis or a history of allergies, we recommend 30 minutes. Most of the places that give the vaccine are going to be prepared to treat people for an allergic reaction.
Okay, and what if you've already had COVID? Or do you recommend that you get vaccinated?
It's a very good question. The current recommendation is that you get vaccinated 90 days after your original COVID infection. And the reason for that is we think that during the first 90 days you're immune. And so we recommend after we don't know if you're immune or not anymore, you get the vaccine. It should be noted that because people who have had COVID have already made antibodies to COVID, they're the ones that seem to have more of the fevers, more of the chills, more of the flu-like symptoms with the vaccine. Mm-hmm. So people who have had COVID should wait 90 days, get vaccinated at that time, and be aware that they are more likely to have the flu-like illness side effects that occur with the vaccine.
Interesting. So that would be true for first responders and medical professionals as well?
And we've had a number of people who have had COVID that have already been vaccinated.
Okay. And my understanding is these vaccines have been approved for adults and not children. Can you talk about when there might be a rollout for children? I realize they're less susceptible to COVID, but nonetheless can still get it.
Well, the reason that they're not approved is they haven't been studied. So I assume they're going to be studied in children. My guess is in the next 6 months to a year. Part of the issue is, though, that vaccinating children, even though they're at lower risk of complications of the disease, children are typically reservoirs of any virus. So one of the things we've really learned about this virus is you might not get sick from it, but when you come home and give it to your mother or father, or worse yet, your elderly grandparents, they get very sick. And there's a statistic out there that something like half of the people who are infected by someone in their own home, meaning the grandparent is living with the grandson who's out working or yet going to bars, something like that, gets sick, doesn't even quite realize they're sick, comes home, gives it to the grandparents, and they get very sick. So one of the reasons that it would be important to vaccinate children is that it would probably really slow down the disease because they won't infect their parents, who won't infect the grandparents. In addition, this works for other viruses. So for example, one of the best ways to prevent the flu in grandparents is to vaccinate their children and their grandchildren so they don't infect them. So we assume 6 months to a year, when it's studied, when we know that it's safe, that it'll be approved for children. But the it isn't that we think that it's dangerous for children, it's that no one studied it yet. Those studies are going to be ongoing.
Interesting. Can we talk a little bit about what percentage of the population would need to be vaccinated in order to help us get to the other side of this pandemic?
Probably, my guess is about 2/3 to 3/4. Part of the problem is how much of the population that needs to be vaccinated depends on how infectious the virus is. So for example, measles, which infects every single case of measles, if it's in a population that is not immune to measles, infects 10 to 12 people. And you need vaccination rates in the 90 to 95% range because the vaccine spreads so easily. For COVID, in the absence of social distancing, it probably infects 2 to 3, maybe 4 people for every person that's infected. And with social distancing, we actually over the summer got it down to less than 1. And the guess is somewhere between 2/3 and 3/4 of the population. What that means is that for the United States with 330 million people, somewhere around 275 million, somewhere around 300 million need to be immune or vaccinated. And then you get what's called herd immunity, meaning the virus just doesn't spread easily in the population. On the other hand, as soon as we hit about 100 million, about a third, the virus probably slows down a little bit. It just simply has a little bit of a harder time finding someone who is not immune and that it can spread to. And so even if we don't achieve herd immunity, we will probably see a slowdown in the rate of the disease simply because more and more people will either be vaccinated or have antibodies or be immune from being infected.
And here's a tough question. Do you think we can achieve that without mandating the vaccine?
Yeah, I do. But I do for a not nice reason. Mm-hmm. I think everyone who doesn't get the vaccine is going to get infected. So I think that if you choose not to get the vaccine, you're going to get COVID and you'll be immune. You'll also take a much higher risk of ending up in the hospital, ending up really sick, ending up dying. So I personally think that the vaccine will get us to herd immunity much quicker. But if you choose not to have the vaccine, you're going to get this disease. And when you get this disease, you're going to eventually be immune, and eventually it'll either really slow down or it'll become something more like the flu. But yeah, no, we'll achieve herd immunity. We'll either achieve it because we get infected naturally or we'll achieve it because of the vaccine. We talked a little bit about people not being that sick. And most people think the mortality from this disease is about 0.5%, 1 out of 200. And that, what you'll see on Facebook is 99.5% of the people survive this disease. That's absolutely true. But 0.5% of 300 million people is somewhere between 1 and 1.5 million. So even if this virus only kills 1 out of 200, if it were to just simply go through the population naturally, we would have about 1 million Americans die.
Yeah. Staggering. So I'll put this in the context of I'm considering, as an employer, making the vaccine mandatory for city employees due to the pushback that we've received from initial surveys of willingness. Maybe that will change as conversations like these happen and more people find out more information. But would you recommend employers consider mandating the vaccine for their employees?
UPMC Pinnacle for healthcare workers, we're not.
I know.
They're two
Why
very.
not? Yeah.
Because the vaccine just came out, and the last thing we want is to force someone to get it and have something bad happen. And you have to understand with any vaccine, bad things happening have to be distinguished from bad things that just happened anyway. So, for example, we always talk about Guillain-Barré syndrome. It's a paralysis that you can get from the flu shot. Well, actually, that occurs in the general population at about a rate of 1 out of every million or so. And so it's very hard to figure out whether the patient got it from his vaccine or it just happened to happen. In fact, with this case, you're actually much more likely to get Guillain-Barré from the flu. And the second thing is, I truly believe that what's going to happen is people who get the vaccine won't get COVID, and people who choose not to will. People will see that and gradually on their own decide that they want to get the vaccine. We originally, when we heard this, it was quote unquote fake news, especially in Pennsylvania, especially in Harrisburg. I don't think anyone believes that anymore because we've seen how full our hospitals get. We've seen how our sick people get. We've seen how full our ICUs get, and we've seen how many people die. What will happen to the people who don't get the vaccine is they'll get COVID. People will see that as they see that people who have gotten the vaccine really don't have many side effects. The initial resistance is going to fade.
Well, as an employer, I'd like to push back gently against UPMC's decision not to mandate it for its employees, because I think it sends the wrong message in the sense that if healthcare professionals aren't willing to get vaccinated, and I assume you have a fairly high percentage of employees that are refusing to get the vaccine, it sends that message to everyone else. And that's been the number one argument for our police and our fire has been, well, if the UPMC workers aren't getting vaccinated, then clearly we should wait too. So you don't have to respond to that if you don't want. Okay.
First of all, you're welcome to push back. God, most people aren't respectful when they do. I'll push back with you. We have seen how much people want this vaccine. We have 300 people show up to be we have 300 people show up to be vaccinated at a single clinic. I can't tell you how upset people get if there's a delay in getting their second shot. I can't tell you how upset people get if they, for some reason, think that they're going to be left out. So the healthcare workers, the ones that you're saying, well, UPMC isn't mandating it. Part of the reason we're not mandating it is something like 80% of the people who have responded so far have said they want the vaccine. And as someone who sometimes has to bear the brunt of the people who aren't yet on the line to get the vaccine, I can tell you the healthcare workers really want it, because when they don't get it, they get upset.
Well, fair enough. I can just tell you that our internal polls at the city show under 50% are interested in getting the vaccine at the moment. And that is As you know, in communities of color and elsewhere throughout the country, there are different perceptions about vaccines that is going to make it harder. But I guess that's why these conversations are important and why we're trying to get the information out. But in order to achieve the relatively high population percentage, as you say, without everybody else having to get COVID, I feel personally that we may need to see employers mandate it, and we may need to see the government mandate it in some instances.
My daughter is in college, and one of the first things they did when she was allowed back on campus was said, if there's a vaccine, you have to take it.
Right.
Let me also just quickly address communities of colors, because there is a long history in this country of communities of color being treated unfairly by the medical system. There are things like the Tuskegee experiment, which gives communities of color understandable suspicion of the medical system. On the other hand, this disease is affecting communities of color at much worse than it's affecting other communities. And that's probably because communities of color tend to live in multi-generational households where the grandparents are at risk of getting sick from the grandkids. And communities of color frequently have less access to medical care, sometimes have more coexisting conditions. But this disease has actually affected communities of color harder, more severely than other populations. So I understand the suspicion of the medical system. I understand why they're reluctant to get a vaccine that just came out. On the other hand, for communities of color, their risk of the disease is actually much higher than the general population.
Great, thank you. And I think the intergenerational household answer sort of ties back to those questions at the beginning of the program about the BioBot data. Why is the virus more prevalent in Harrisburg, a majority minority city, than in other communities throughout the country? We should talk, we're running out of time, but just a couple quick questions. There's a lot in the news about these new super strains or powerful strains of COVID. Is this something from a vaccine standpoint that we should be concerned about?
It doesn't appear to be. Now, again, the super spreader strain did in fact just appear in Dauphin County. Mm-hmm. We have a case of it here. I assume that if we have a case of it here, we're going to have more cases of it here quickly. But the super spreader vaccine is about 75% more infectious, which means that it is much better at transmitting itself from person to person. It still has the spike protein that the vaccine makes antibodies against. And from what we can, the preliminary data is that the vaccine is effective against this. The worst case scenario, I believe, is that it's a little less effective. So instead of 95%, it might be 85%. But it appears to work against this strain of the vaccine. And even if it doesn't work 100 just as well against this strain, it's going to work almost as well.
Great. That's good. That's certainly good news. And if we could just talk about testing for a moment, with the focus now on the vaccine, is there less of a focus on testing? And what is the current capacity, at least for our testing here in the city?
So the capacity is good. We've actually had a huge increase in testing capacity since the spring. And I still think, so first of all, if you're in the hospital and you have anything resembling COVID, you get tested because we do things differently. We give you, for example, steroids, which clearly prevent you from getting as sick. We give you a drug called remdesivir, which probably slows down the virus. And we have to do different infection control. We have to make sure that you don't spread it to other people. I think the biggest reason for testing is, one, so we know where the virus is, but more importantly, if you know you have COVID, you're going to be more careful and not spread it to friends and family members.
Right. And so in terms of capacity, the testing center that UPMC has on Paxton and Cameron is not oversubscribed. And what's the status of our hospital capacity?
Hospitals are full. So our hospitals are very full. Now, fortunately, our mortality since the spring has gone down. The length of stay, people who used to be in the hospital for 16 days are now in for 6. We have gotten better at treating this. We understand that you shouldn't put someone on a ventilator because once someone ends up on a ventilator, they have at least 2/3, 3/4 chance of dying. And so even though we have more patients in our hospital than we did in the spring, we have more disease in our community, but we haven't exceeded, our hospitals are very full, but we have not exceeded, for example, our ICU capacity. Good. I will say that we're all very tired, that we are dealing with volumes that are very high. Our ICUs are pretty close to their capacity. They're not over. And so one of the things I really stress is we need the public support. We need them to wear masks. We need them to do things to prevent them from getting COVID. And also within 6 months of a vaccine. So if you can keep yourself well until you get the vaccine, you're not going to get COVID. If you can keep yourself from getting very sick, keep yourself out of the hospital, and keep yourself from dying. Every person who doesn't get COVID and doesn't die in the next 6 months is a life saved, because eventually they'll get the vaccine. They are much less likely to get COVID, and they will be much less likely to die.
Mm. Yeah, you mentioned mask wearing and the importance of mask wearing, and that's something that's obviously a message that we've been constantly putting out there. One question related to that I got yesterday, I forgot to ask you this, but so if you get vaccinated, will you still need to wear a mask?
Actually, no. But for now, until the burden of the disease goes down, until we know exactly how well this works, we're telling people to continue wearing masks. I was vaccinated about 3 weeks ago, and in about another week or so, I will be considered to be fully immune. You couldn't pay me to not wear a mask. Mm-hmm. And that's simply because there's still a lot of disease around. We assume that the vaccine is going to work, but we know the vaccine plus a mask it'll be very unlikely that you get the disease. I will stop wearing a mask when the disease stops becoming common in our community.
Right. And I read somewhere that while you may not be affected by the disease, you might still be able to carry the disease and spread it.
So this is a little bit of an over-exaggeration. What the president of Moderna says is they did not specifically study whether the vaccine prevented infectiousness, whether the vaccine prevented you from giving it to another person. They only studied whether or not you became sick. Every other virus that we vaccinate against prevents people from both getting sick and infecting other people. So unless this virus acts differently than every other virus, you should be both immune and it should make you non-infectious. We're obviously going to study that. We're obviously going to prove it. The issue is that in the original trials, they didn't do that.
Well, thank you for that. And thank you, Dr. Goldman. I think this has been a very interesting and informative and wide-ranging conversation. We normally on these Facebook Lives just turn it over for a moment or two to Momin to see if there's some questions from the public that have come in while we've been talking. And Momin, I'll turn it over to you now.
Yes, thank you, Mayor, and thank you, Dr. Goldman. There's a few questions here, one of which you already answered, but just to kind of clarify, about spreading the disease from somebody who's vaccinated to somebody who's not vaccinated. The way that this disease spreads, for example, if somebody touches a surface and there's a COVID disease on that surface, and then shakes somebody else's hand, even if that person who initially touched that surface is vaccinated, can it be spread like that?
So the main way this disease is spread is airborne. It can go by surfaces. For both airborne and for surfaces, you assume that if you're vaccinated, the amount of virus you're going to be breathing out is going to be much less or none at all. So The worst case scenario is that the vaccine will make you much less infectious. The best case scenario is it makes you non-infectious.
Okay.
But it should work both for breathing and both for touching surfaces and getting it on your hands.
Okay, great, thank you. Regarding the general public, could there be a scenario where the vaccine becomes mandatory for everyone to take?
Other vaccines often are. So, for example, it's required that you get the measles vaccine before you start school. If I were to, I left my crystal ball at home today, but if the vaccine turns out to be as safe as we think it is and effective as we think it is, once we get experience with it, it wouldn't surprise me if it becomes mandatory. And so, for example, when people want to travel overseas, right now you have to have a negative COVID test often within 72 hours of your departure. Wouldn't surprise me if you want to go anywhere outside of the United States or travel within the United States, there may be places that require you to show that you are immune to the virus.
Next question is, when the vaccine is available, how will I know when it's my turn?
That's a great question. I wish we had that figured out. The best thing to do will be to call your doctor and ask and say, can I get this? It also depends on how they distribute it. When it goes to the general population, I suspect you'll be able to go to your local drugstore and get it. And there's going to be all kinds of publicity and rollouts, so you will know when it's available.
Okay. All right, next question is, you had mentioned the protein is what causes the immunity. Why aren't vaccines like the flu similar to this vaccine's protein approach?
So the vaccines like the flu are similar to this protein's approach. However, what happens is the flu virus changes a little bit from year to year. And so this year's strain is a little bit different than last year's strain. And so as a result, you don't have full immunity. One of the things that isn't clear is if this virus is going to change a little bit and we'll need a second vaccine. It's only been around for one season. We just don't know that yet. But it's the same approach in vaccination. The difference with the flu is the virus changes a little bit year to year. So the vaccine also has to change a little bit year to year.
Okay. And maybe a bit of a follow-up to that is the shots. You had mentioned about 2 shots. Is the second shot a duplicate of the first?
It's exactly the same shot.
Okay.
It's just your immune system produces a stronger response after the second shot, but it's exactly the same shot as the first.
All right. And I think that's the last question, but we do have a comment that I want to share from Michelle. She says, thank you for hosting this conversation. Very important information.
Okay. Thanks. Yeah, and thank you, Momin. And thank you, Dr. Goldman. Really appreciate your time, and thank you for all the work that you do and UPMC does to help ensure the safety of our populace. We do appreciate it, and we know how hard everyone's been working, and we're all in this together. So we're going to work to constantly get the word out and make sure that we take this virus seriously, that we take advantage of the opportunities that the vaccine brings, and that we eventually get to the other side of this pandemic in a way that allows us to return to some degree of normalcy in our lives. So thank you for joining us.
Thank you very much for having me.
And with that, we will say goodbye till next week. Thank you for watching, everyone, Facebook Live. Welcome to the new year. I'm glad to be back. We'll continue to bring you topics that we feel are important, that are of interest to the public. And we'll see you every Friday at noon right here on Facebook Live.